Our upcoming panel discussion on AI in healthcare brings need for heightened data security standards. We'll delve into this pressing issue to provide answers. So without wasting any more time, let's put our hands together for our moderator, Dr. E. Randy Eckert, Chief Medical Officer of AnyPlaceMD, and panelists, Costas Fantis, CEO of Encode Health, Kris Narayan, Chairman and CEO of MediKarma Inc., Dr. Nathan Price, Chief Scientific Officer at Thorne HealthTech, Joe Oddo, CIO, Board Member and Advisor of Red Eye Network Solutions, and Sujan Sanku, Chief Operating Officer of 99 InfoSystems Inc. Please come to the stage.
Good morning, everyone. Thank you for hanging in there with us. Appreciate it. If you didn't get a stretch, please feel free to stand up and stretch. My name is Randy Eckert. I'm the Chief Medical Officer of AnyPlaceMD, and I will be the moderator for today. Now, that's my sole function. I have an interest in AI, and my specialty prior to becoming a Chief Medical Officer was in pathology, and we were using neural networks and machine learning to help aid in the diagnosis of abnormal cells on pap smears for many years, probably close to 20 now. But that's the limit of my AI experience. We're going to deviate a little bit from the intended introduction for this panel. Everybody knows that data security is going to be important for AI. When this panel was assembled, one of the things I noticed is there's a great diversity of expertise in this panel. And I'm going to give each and every one of them a chance to introduce themselves, introduce their area of artificial intelligence in medicine that they're currently involved with, and give you a brief overview of their perspective of how AI is going to impact medicine in general, not just data security. What I'd appreciate you doing is during each of their 5 minutes, spending some time to write some questions, because this is going to be an interactive presentation. I want most of the questions coming from the audience and not from me. I certainly do have a series of questions, but I'd rather hear from you what questions you have about artificial intelligence in medicine and the impact that you see moving forward. So without any further ado, I'm going to allow Kris to introduce himself and talk briefly about his current forays into artificial intelligence.
Thank you. Can everybody hear me okay? Excellent. So the esteemed panelists here are going to talk about process, procedures, protections. What I'm going to focus is how do you and I see a product? When you use an iPhone, you don't see what's inside. You just see how it looks, how you use it. So when you talk about AI or technology or anything, I'm going to show you how that's going to reach out in healthcare to a patient, to a provider, or a payer, among others. There are pharmaceuticals and pharmacy chains, whatnot. But I'm going to talk about what the last panel touched. What is in it for me? Why should I pay you? How do I benefit? So with that, I'm going to start this with a demo. Some of you may have seen it. So I'm going to show you a product which I hope, as it's getting now deployed by some of the major payers and providers, that you're going to see more and more in 2023 and 2024. It is AI, but it's not like any other that you see, ChatGPT. This is an AI that talks to you, that has a conversation with you back and forth. It does things for you, scheduling your appointments and refill your prescription. And further, you can go back and look at exactly where you are in your life, what are your comorbidities. That's the most important thing. The key thing you ask a doctor when you get in trouble. Hey doc, what do I do next? So let me show you the product. Hey, Jill, how am I doing today?
Hi, Joe. How can I help you?
Elon Musk and Cybertruck demo. Hey, Jill, how am I doing today?
Hi, welcome back. It looks like you're making great progress toward your health and wellness goals. Your health score went up by plus 25 points over the last week. Keep up the good work. Do you want to learn more?
Yes.
Your improvement in score is mainly driven by blood pressure reading, which decreased to 130/80ths of a millimeter of mercury. Your goal is to get to 120/80ths. Secondly, increased GFR score from 60 to 75. I got this information from your recent lab results. Your goal is to get to over 90. You are moving in the right direction. Keep up the good work.
What is GFR?
Sure, the glomerular filtration rate GFR is the rate at which blood is filtered by the kidneys. It is a measure of how well the kidneys are functioning and is used to diagnose and monitor kidney disease.
So, what do I do next?
Here are your recommendations.
So, what do I do next? So, what do I do next?
Your latest recommendation is as follows. Your blood pressure value has recently increased. You have hypertension. It's imperative to implement lifestyle changes to lower your risk of hypertension. Please discuss with your medical provider to help you ensure optimal control of your blood pressure, including lifestyle management, such as the dietary approaches to stop hypertension.
So, just one more thing to tell me what to do with my life, right? But there is an interference between the mic and the microphone on the phone. So, you're hearing some of this reflections. But the point is, we foresee a future where each one of us has a health assistant, a virtual health assistant that knows who you are, HIPAA compliant, knows your diseases, talks to you about how you're doing for the last week or yesterday. And from there, it goes on to converge and tell you what to do next. If we can have the next slide, please. So when you look at MediKarma, this is what you're going to see on the screen. The way this works. As you and I are talking, I create an avatar of you. With your consent or your doctor's consent, I go get your electronic medical records in 35 seconds or so. And I put around your body or your digital twin your health conditions in green, red, and orange, just like traffic lights, check engine light. It's going to give you some information like, what are the chances of you having a heart attack in the next 7.5 years? What are the chances of you getting a stroke in the next 5 years? The intent here is to tell you where you are in your health, show you the weakest link in your chain, and wake you up so that you can start thinking, what is in it for me? What is in it for you when you're 50 and above with a chronic condition? To avoid incarceration inside something called your body, disability, worsening. I'm going to go into what's in it for other segments in a minute. But as we show you your avatar and your conditions, we also take what you're doing today from your smart devices, how you're working out, how well you're eating, what is your stress, how is your mood. We get this information from smart devices, RPM devices, and Jill will be talking to you in the morning saying, I see you didn't sleep well. What's in your mind? What's going on with you? These subjective answers are all computed into a FICO-like score that you see on the left side of the screen. The score will go up or the score will go down. If you had 3 glasses of wine last night, score is going to go down. If you work out for an hour, score is going to go up. So we show you the score drivers. And when you click on any of the score drivers, Jill pops back and tells you what to do to fix it. So this is the implementation of the product. To quickly converge the what is in it for me, we started getting some of the major players in this field coming to us They asked us, can you prove your health score can correlate to claims data? And we very quickly converged in about 6 to 8 weeks. We proved MediKarma health score, over 65 million de-identified users, was able to correlate to the claims data by 90.6%. The moment we did this, we started seeing interest from insurance companies. So the proposition we give insurance company is, if your members use MediKarma, your cost of care is going down. The proposition we give the provider networks, if your patients use MediKarma, their behavior will change the more they talk to Jill. The behavior changes will drive the score up. As the score goes up, your cost of care, number of emergency visits, will go down. So each one, what is in it for me? That's how we put the company together, and we are now deploying the product.
Great. Thank you, Kris. Nathan, tell us your current position in the company you're with.
Yeah, so I just give a little bit about my background. So Nathan Price, I'm the Chief Science Officer for Thorne HealthTech, which is a public company that serves about 46,000 healthcare providers and about 5 million consumers. And in terms of my background on AI, so I'm trained as a computational biologist. So I was in academia for about 15 years as a professor. And in that time, I did a lot of work on multi-omic analysis of genomes and proteomes and metabolomes and microbiomes in clinical labs and wearable devices. And we took several thousand people through health programs using this kind of information and amassed one of the largest multi-omic data sets around health. This was done in collaboration with my partner, Lee Hood. We jointly ran something we called the Hood Price Integrated Lab for Systems Biomedicine. Lee, for those who don't know, is famous for inventing automated DNA sequencing and won the National Medal of Science for some of his earlier work. In terms of some of the things that we're doing in AI at Thorne, very interested, and I'll talk more about this later, in a concept called digital twins. I think I'll save that for a little bit later when we get into that topic in a little more detail. But that's an incredibly powerful way to monitor your health and look for improvements. We've done a lot on the analysis of from genomics and being able to show how it predicts the kind of things that you can change about your health and the kind of things that you'll struggle to change, such that you can provide personalized health plans for people. That's a big area of interest. And then the other thing that I'll say about that is we do provide testing coupled with AI to give people personalized recommendations derived from a lot of background health and molecular information. And then on another policy side, I just finished co-chairing a series of workshops for the National Academies of Sciences, Engineering, and Medicine. That was a joint between the State Department and several countries in Southeast Asia, looking at threats of AI and biodata. And that report, if anyone's interested in that, was released last week. And I'll turn the time over to you.
Joe, please.
Can you hear me?
Yeah.
Yeah? Okay. So Joe Oddo, Chief Information Officer for the past 3 years in a healthcare company. I also, I'm on a few different advisory boards. Probably the relevant ones are cybersecurity, network cybersecurity advisory board, another company that does medical management with a lot of healthcare providers, and also then an AI analytics company that specializes in AI analytics as well as our. And thanks. And then the other side of it is I've been recognized for a few awards this year in particular. One was top 10 CIOs in healthcare. The other is on the technology side, top 50 in the US for technology professionals. As far as AI goes, currently what I'm seeing is a lot of regeneration, next gen of a lot of the chat bots that a lot of the healthcare companies have. So you can answer questions, healthcare questions, or you can answer where's your claims, those type of questions. So you're seeing that go to the AI side. I'd say over the next 2 to 3 years, what I'm seeing and working with different companies. One is access, so AI access. So I'm seeing a lot of passwordless credentialing. A lot of it is blockchain related, peer-to-peer, so you can really save what you have even to your Apple Wallet. And I'm working with a company that does it for credentialing for our university, large university in Arizona, that you can save your credentials, your degrees, that type of thing, and share it with who you want. And then also I see that in the healthcare side, they're trying to get in applications and will over the next couple of years with the individual sharing medical records as little or as much as you want with your healthcare providers. So that's kind of the direction access-wise. The second item would be safety. So it's a lot of wild, wild west right now in AI. And we're seeing a lot of safety come in, which is a great concern from a CIO perspective and a company perspective. They don't want to give up their IP. So you're seeing a lot of AI safety companies coming into the marketplace. One I'll mention we talked about was Anthropic, which is working with Google DeepMind, and a heavy investment from Google, about $400 million in that company to develop kind of a steerable and reliable safety solution. It's a lot of the former founders of OpenAI and ChatGPT that are working on it, kind of broke off in a company. So we're seeing that on the safety side. And the last area I would say, and similar to what Kris had, was interactive AI solutions. So providing data from the outside. I see your blood pressure, your genetics, different information about you, you provide to an application, maybe via your Apple phone or Google phone, and it will come back with recommendations on specific care provided. So those are some of the things I see going forward.
I'm going to keep my personal introduction brief. You could probably just find me on LinkedIn. Our medical solution, what we are working on, is quite different from what's out there in the market or what people are working on. Ours is more for first responders. So basically, I think the biggest issue we face in the medical industry right now is when you make a call, there's a delay between the ambulance arriving and the EMT or whoever is on it to perform any medical procedures. And then from there to get back to the hospital, most of the countries, the EMT can't actually do much. Maybe they can resuscitate you, do the CPR, maybe give blood, depending on the country, maybe adrenaline also depending on the country. So our solution is basically like a virtual EMT. So whoever the first responder, whether it's like a bystander, like you or me, or whether it's a professional, it'll give you the advice you need to keep the person alive. Whether it's alcohol poisoning, whether they're giving birth, whether their heart has stopped, whatever the case may be, you use your phone, you videotape it, it's a live stream, and it'll analyze what's happening, and it'll give you, hopefully, you're still working on it, adequate advice on what to do. So how many of you have actually had emergency training, like CPR or, obviously, right, health panel. So how many of you have actually performed in the public CPR or anything? Okay, so I actually had the sad opportunity to do this in Tokyo in February. There was a person who, I don't know what the case was. I think they just had too much alcohol. They're completely passed out. And there were no police around. It was like 2 a.m. I was also drinking, by the way, very, very honest. Mm-hmm. So there was no one else to obviously help this person. So I had to call the ambulance, get people involved, do the CPR. It was very high stress. And honestly, you can't do CPR for too long. Like the whole chest compressions is really hard. So I would have preferred if there were more people to help me and some guidelines. Obviously, I've done the training, but in practice, it's very different. I'm scared. Am I going to kill the person? Is he going to die? Though I try to help, it's a very stressful situation. So our solution hopefully will guide you through, keep you calm, and pass the baton to whoever is more professional when they arrive. And in terms of AI, we'll come back to that later.
Thank you. Hello, Las Vegas.
All right, you're not from the States, are you?
No. Hi, my name is Dr. Costas Fantis. I've studied medicine. I have a specialist interest in neurosurgery. I'm currently doing research with the University of Buckingham with a focus on the applications of artificial intelligence in neurosurgery. We're looking at how artificial intelligence is being applied to the use of biomarkers in primary neurosurgical tumors. And I'm the CEO of Encode Health. You would have heard from Dr. Carlon Fitzpatrick, my business associate, talk about Encode Health. I am the CEO of Encode Health, and we apply artificial intelligence to optimize medical inventory in hospitals. And we also provide different types of functionalities to ensure post-market surveillance once a product is inserted into a patient to ensure that that product is actually working the way it does. Happy to answer any further questions about what we do, but in summary, that is what we do.
So thank you very much. The one thing I will point out to the audience in hopes that will encourage you to ask questions is you have some of the most diverse voices of AI in healthcare that are out there. And so I would encourage you to ask those questions. Please. I don't think you're from the United States either.
How did you know? Yeah, we've got a reputation here, haven't we? But my question really, so for the chap sitting next to Cos, or your name again?
Sujan.
Sujan. Your innovation sounds fantastic. And I mean, I've been a first responder in hospital, and even with the appropriate training and been ATLS trained and trauma trained, it's quite intimidating. My question is an ethical one, really. So where does the responsibility lie in the event that there's an adverse incident or a poor clinical outcome? So from your point of view and your team, where's the responsibility?
At least in the United States, in most states, it's mostly state government, there are things called bystander laws. And as long as you're trying to help someone, usually you're in the green. I say usually. You can still get sued. It's a very litigious country. So that's a totally different topic. I think that's beyond the scope of like a legal disclaimer on the app. What we want to do is reduce wait times and save the patient. So as we have an ethical responsibility to save someone. That's the health approach. And the legality of what happens after that, I know it's a huge issue, but I don't think we can stop it in a country like US. In other countries, besides the US, it's common law. If you're trying to save someone and you accidentally break their arm off or break the rib cage or whatever, you're completely in the good. Like I said, US is a bit tricky, but we are trying to lobby so that we can get more support from the general public. It is a system that kind of jumps on the 119 call, or in this country it would be 911.
911.
Yeah, sorry, that's the Japanese emergency number, or 112. Some countries in Europe and India included. So we do have the government services that are involved in the loop. So somebody in that loop would be taking responsibility. Hopefully not the developers, not the the software developers, but that is something that I honestly don't know the answer to, and I think it's a very risky thing. But at the end of the day, all you want to do is save the person. So if you get sued saving someone, that's sad, but that does happen to even doctors performing at hospitals. I think, again, more so in the States, especially with malpractice and other things. I've never heard of this happening in Japan where I live. You do not sue the doctor. He's like God, because he, connects life. He gives you life in that way. So I think that's more of a cultural thing than a legal thing in my mind. Does anyone have a different opinion?
Yeah. So I think in most states in the United States, those laws, while they may be referred to as bystander laws, are also called Good Samaritan laws. And so if you're acting in good faith in the best interest of the patient in an attempt to save their life, then legal protections do exist for you. Doesn't, like he said, doesn't prevent you from being sued, but it does offer you protection from that as well. And I don't know if anybody else has experience with that at all, but I have had several colleagues that are, have been subject to lawsuits after trying to provide aid to patients who have been found not guilty, and the suits have been dismissed. So,
And would that extend to healthcare professionals as well?
Yeah.
Would that extend to healthcare professionals? I mean, there's a difference
Yes.
between
Yes.
a layman providing care and a healthcare professional
correct, it
providing
does.
care based on an AI algorithm
Right.
in an hospital setting. Because the argument would be from my regulatory body, well, you have clinical judgment, you have training, and so it's difficult to hide behind the technology that you're using
Right.
to make that particular decision.
I think probably the more important question is at what level is the instruction being provided by the AI similar to what someone who is trained as a medical professional might provide in that circumstance. And I don't know what kind of data set you're using to try and create or recreate that environment.
This does take into account quite a few scenarios, at least that we could come up with. For example, you could have burns if you have jewelry, pretty common, I think, especially with AEDs. The other scenario is sexual harassment, especially if you need to maybe take off a lady's bra or open up the buttons, and there are other people who are just filming, who are basically not helping, but they're just there. So we have thought of all these scenarios, potential scenarios in the public and in the professional, so like in a hospital. But usually if you're working in a professional capacity, so if you're doing it in a hospital, the hospital is a buffer for you. Unless you're completely doing it as like a non-duty doctor, which is, again, that means you're probably in public. So then the standard rules apply whether you're a doctor or not. So unless you made like a grave mistake in the hospital setting, you should be protected by general law. As far as what we research, like I said, again, US is a bit more on the tricky side.
It is very tricky. Yeah. Does that answer your question, sir?
Yeah, to a certain extent. Thank you. Yes.
Okay, sure, no problem. Any other questions? Please step to the mic if you have a question. Encourage you to do so.
Good morning, guys. My name is Kira Howard. I'm a patient experience consultant. So when I'm listening to all of this, I'm always thinking about the end user. I'm thinking about the faculty, the staff that actually have to use the technology that you guys are supplying. So from the top down, everybody's very excited. We have access to all this data. We can do this and this and that. But how do you guys get the buy-in, or how do you think you get the buy-in from the staff to actually learn how to use the application, be able to educate it, like the previous person that was up here was talking about educating the actual patient on how it's going to be used, how it can help, reduce turnaround times for you waiting for the nurse practitioner to call you back, or for the nurse to call you back. So what is the engagement factor for not only the patient, but the person that's in the office that would be essentially selling the product to the patient to get them to buy in to use it?
So that might be a good question for Kris, since he demonstrated an app that, patients could potentially use. But you're right, there are challenges in teaching anyone how to use that kind of app appropriately.
So can you hear me okay?
I can, yes.
Very good. So when it comes to technology, we have many things we use in consumer electronics. Keep it simple, right? There's a word, he's saying it, not me. But I'll say the other word, something called idiot proofing. So when I invented smart TV, I told my team, don't look at 21 button remote. This is Joe's six-pack with a beer in his hand. Brain is not working. More than 5% capacity. Click, simple click. Put 4 things there that show streaming. Click one of them. Make it so simple. People are going to get, for lack of a better word, addicted to using it. Fall in love. So Steve Jobs says a couple of things. Insanely great product. And making it with the end in mind, the user in mind.
Correct.
Going back to what MediKarma does, we have 4 stages of engagement with the patient. Somebody gives us a lot of patients, payer, provider, whatever it is. First step, get them to motivate, to enroll. So we put something called what is in it for me? What are you going to gain? Second, once you enroll, onboarding them. You basically have 1 to 2 weeks to make them fall in love with the product. Once you onboard them, now come the next step 3 and 4. How do they use it? How do I nudge you? You step on a scale, I'm sending you a message. Congratulations, you lost half a pound. There is fire outside, I'm sending you a message. There's a smoke out there, be careful. It's called Jill touch points.
Okay.
So we give you many touch points to reach out and touch you. So you're continuously engaging. And the more you're going to engage with Jill, the more your behavior is likely going to change. And the more your behavior changes, 3 different segments get 3 different things. Patients feel healthier, payers get cost of care reduction, providers get their value-based care bonuses.
Okay.
So that's what we do.
So
So
I-
we actually train not just the patients like this,
With
we
the staff
also
as well.
train the caregivers on how to use this,
Yeah,
how to talk to them.
I can see an insurance company really buying into that and saying, as one of our insureds, if you use this app and share your data with us, then we'll reduce your premium by X number of dollars in the next year.
Great point,
Definitely.
but there is a tricky answer there. Insurance companies are seen as people who want to take your money and you can't be too careful in sharing your data, right? So with insurance companies, we do 2 things. One, you give us the data of your members that you want us to work with. 2, we're not going to do any giving you data back. We're giving you what's called predictive analytics. How many of your patients are consuming the most amount of money on what diseases? We'll tell you what you should be doing to reduce your cost. Who should you be sending messages to better take care of themselves? So we have convinced the insurance company that they should pay the money for MediKarma subscription so all the members get free. So they pay a licensing fee, they pay a per patient per month, and if we do reduce the cost, we get 1 PMPM for every 1% cost reduction. Right? What is in it for them? Cost reduction. What do they pay us? Our recurring revenues.
And do you think in underserved communities, this would be something that could be pushed?
You're putting a series of great questions. So, yesterday there was a panel called Health Equity. You want to talk to people you're comfortable with. We provide you Jill in multiple ethnicities, multiple languages, and multiple conditions. There is a diabetic Jill. There is an obese Jill. There is a wellness Jill. So Jill finds out who you are. Then she transforms herself to be talking to you. That's how we are making people feel comfortable.
That sounds great. And just before we,
Yeah.
does Jill talk in layman's terms or does she talk like a doctor?
Jill has to keep it simple.
Okay.
Jill has to be conversational.
Okay.
We spend a lot of time training Jill, but it's Jill. You bring in a healthcare expert, wellness expert, he trains and he creates Jill to be like him.
But she doesn't use medical jargon. She does speak like how you and I would speak.
That's right.
Okay. That's awesome.
Costas, you had a comment?
Yeah, with reference to how we're using artificial intelligence and engaging some of the users, there's 3 things that I would like to say. One is making sure that the user interface and the user experience is of a very high standard. A lot of people don't really accept Tim Pot kind of products nowadays. It has to be of a standard that's something similar to Facebook interface, for example. So at Encode Health, we brought in specific designers in healthcare to make sure that it is of a very high quality level. So that's one thing, to make sure that the design, the user experience is exactly what they would expect of a modern day app. The other thing that I would have to say is to do with trust, making sure that if somebody is going to engage with an application that is using artificial intelligence, there needs to be some kind of trust accountability. And we've looked at the European AI Act and looked at what transparency is required to make sure that what the output is trustworthy. So we produced two types of links. We've created a link that is associated with the version of the algorithm itself. And we've also created a link associated with the data set that has been used to generate the output as well. And also with the regulations that that particular algorithm is compliant with. So user interface, trust, and also making sure that the product actually does what it's supposed to do. So for example, we use optical character recognition. It's a type of artificial intelligence that when you take a photograph, it recognizes the characters, the letters, the numbers that are in there. So when we're onboarding new products, or when one of our clinicians is onboarding a new product, they take a photo and it gets that information and puts it into our database in a very slick manner. So there's a kind of usability trust there as well. It does it when it says it's supposed to do it. So those are the three things that I would like to offer as how do we engage with our stakeholders, making sure the interface is of a high standard, making sure the transparency and the trust is there, and then making sure generally that it does what it's supposed to do.
Does that answer your question?
It did. I just wanted
Terrific.
one other thing. I'm pretty sure that you guys have probably come up against, just some negative feedback in terms of taking the human aspect out of it. And I just wanted to know, from all of you, what is your go-to to overcome selling AI versus the human interaction?
So I think the question is obviously people prefer talking to other people instead of apps. And for some people that creates a difficulty. And so the question becomes, how do you overcome the fact that you're telling your patients now you want them to talk to an app instead of a real person? Joe?
Yeah, so part of the answer is humanizing it. So even the Jills or the chatbot, but also you provide an out because sometimes things get complex and they need more detail. So you have to be able to hit O for operator and get to a person to maybe delve into it a little more fully. But I would say for cursory AI type information, like what's my claim? Have they paid my claim? Basic healthcare information. AI is consistent. That's one thing. And, it gives the same policy to everybody and can answer most of the questions. So that frees up a lot of the doctors, nurses, clinicians for other more detailed work.
Mm-hmm. Yeah. Yep. Let Nathan comment and then we'll let Kris comment.
Yeah, and so the one thing I'd add to that is just that AI can also make our interactions like human to human much better, right? Because if you think about the interaction that you have with your doctor now, it's very likely that he or she is looking at a screen, right? Rather than at you, for example. And there's also a huge amount of time that doctors absolutely hate in terms of transcribing all these notes at the end of the day. Most doctors, if they say, it's their bane of their existence, right? They hate this more than pretty much anything. And when you put AI in there, all that transcription can now be done in an automated fashion. You can have an interface back and forth. And I agree also with the previous point that there's, that sometimes you want to talk to a person, but you can spend hours with the AI getting detailed information and then only have to go back to the provider when there's, a real issue. And the ability for us to also offer medical information at way less expensive, more available 24/7 all the time through AIs is massively better than without. So I think it's going to actually bring a lot of the humanity back into medicine.
Kris.
So we may be looking at the wrong problem here. We have a problem with health equity. You have a shortage of providers. You have burnt out providers. You have a system that's squeezing dollars out of everything they can for profitability. And then you have an increasing demand for services because people are getting more and more sick. So how do you chop off the demand and increase the supply? That's a question to ask first. And then you can say, when you do that, how do you make it as easy, as pleasant, as human as you can do? So let me answer both the questions. AI as conversation AI, as an actionable AI, is not going to replace doctors and clinical nurses. It's going to complement. It's going to provide additional ways of interacting and asking your questions that you don't need to go to your doctor to ask. That's what we're doing, right? But having said that, coming from the consumer technology, I totally agree. You need to make it as pleasant, as easy, as idiot-proof as it can be to communicate and converse with whatever form you're interacting.
3 seconds. Go ahead,
I
Sujan.
was thinking more like 30 seconds. So there is something called sentiment analysis. Cisco is the leader. So it basically engages your facial expressions, your voice tones, and it will subjectively answer kindly, like a doctor in a good mood. On the other hand, sometimes a doctor, a human, can be having a bad day. So they might not be so interested in engaging. We are human, we are fallible. But the AI can be trained to be always a kind doctor. So I just wanted to leave you there. I know it's a complicated topic, but
Yeah, no, very. Next question, please.
Thank you. Just a thought. Well, I'll preface my question with a question.
Close to the mic, please.
Is that better?
That's better.
Much better.
Thank you.
Thank you. Who flew here? Okay, great. Anybody go to the grocery store since they've been here? Or maybe last week?
Yeah.
Okay. So what was your check-in experience like at the airport? Did you use a teller or like automated teller, or did you use a real person? Automated? I'm assuming you checked in online maybe?
Mm-hmm.
Actually, I didn't check online. Just went. I bought the ticket using an app, and then
Okay.
I went to Heathrow. They gave me a ticket there, and I walked through. Yeah.
So you're like a technology whiz, kind of in a way. Yeah. And what about when you go to the grocery store? Do you use the automatic checkout or do you go to the slow line?
Self-checkout.
You have
Self-checkout.
Okay. So I've done a little preliminary experiment on who doesn't do the self-checkout and who doesn't do the automatic check-in. And it tends to be an overrepresentation of the aging population. So my question to you guys is, have you come across any genius ideas to ensure how the aging population doesn't get left behind in this technology revolution?
That's actually a great question. As someone who's in that population, you know, if I don't pay attention to how things are going and changing, I could very easily be lost. And, you know, my elderly parent has those challenges all the time. So it's a great question. And how do you overcome the fact that the majority of your users are going to be in that age range where they're comfortable with that technology?
Yeah.
What do you have to do in order to be able to overcome that age barrier?
Well, I actually helped to implement a technology at Guy's and St Thomas's in London, which was specific to this problem, but also to do with women's health as well. And we simply used the technology that they were used to, so telephone, but we adapted our back-end system. So when they would dial a specific number, we just told them, this is your specific number. This is the number that you have to dial in. We gave the same number to every single patient. When they dial in, it just brings up automatically in front of the doctor their specific records. Obviously, we do some kind of checks as well. What's your name, date of birth, your address, and then the doctor who's taking that call would simply continue with the consultation. every consultation would be different. Most consultations last less than 15 minutes. And if there is a requirement to see face-to-face or do a specific kind of test, that's arranged by the back-end system. That the patients themselves, only if they wanted to, could log into their records, but they didn't need to. Everything was done on our side for them. Yeah, that helped reduce waiting times for gynecology from about 8 months to days, hours, even in some cases.
Very interesting.
I have a remark on that too. You look at the grocery chain.
Sure.
Sorry. The grocery chain example that you gave, who goes to self-checkout versus man checkout? People who have a lot of products, they want to go through scanning, right? They go to the man. People who are kind of older types that don't want to deal with self-checkout, right? There is parallel here too. So when we did the deployment, we learned lessons. We found out in one of our deployment, people 75 or 80 and older didn't want to deal with our product. People who don't have smartphone can't deal with the product, right? So we found the sweet spot, 50 to 65 or 50 to 70, that had chronic conditions, adequately tech savvy using a smartphone. So you come across it like that. So we learned lessons and we converge. There are two segments we look at, 50 and older with chronic conditions, 30 and older that wants to look good so they can join a dating site. So.
Last question.
Okay, Dr. Emily Van Dyke. So I have a US-centric question, but I'd be very interested to hear feedback from anyone. So a little more than a year after Roe v. Wade was overturned, just sort of on the idea of trust in women's health, I was particularly interested in a May 9th article from the Washington Post about how Google searches will track visits to Planned Parenthood, for example. And so when you're dealing with young women who are trying to make sure they know the most about their health and also doctors trying to serve them, how do you reassure people that passive data retention couldn't potentially lead them to prosecution when they're just trying to be healthy and fully use their AI and in-person health resources?
That's an excellent question. That's really a critical key element of security in AI systems like this. And how do you ensure or guarantee to someone that they're not going to be used to sell stuff to? So, Joe?
I can start on that. So relative to security of the information, there's a lot of, I mentioned some AI safety solutions that are coming about. Some are reliable as far as policies and can project those policies on the data coming in. Also the data that you provide, right? So if you provided some of your personal information, let's say, and you're a young woman, like you described, you can protect some of that information, not share all of it. So it's what you provide. Also, I mentioned before a lot of passwordless credentialing from an access perspective. So you can actually save on your Apple Wallet your medical information and only share specific information with an application. You don't have to share everything. So that's control on the, let's say, the individual woman's side. On the actual AI side, there's a lot of, from a CIO perspective, in organizations, they're afraid of a lot of sharing of data of their own IP, out in with ChatGPT as an example. So how do they protect that IP? So any internal information that you provided, some of that is done with generalization of populations. Probably Nathan could cover that a little bit more in detail.
I think it's a great point, and it's obviously of high interest. So from a legal perspective, there are a number of protections certainly that fall along with HIPAA and the American CARES Act and so forth about what information can be used as. But I think one of the most important things from a policy perspective, especially as we try, because aggregating data obviously has kind of huge benefits for all of our health, but it does come with some risks, as we're talking about. One colleague of mine who served on the PCAST, the President's Science Advisory Council, and we had a long discussion about this one night. And one of the things that really emerged out of those discussions was how important it was that the focus be not so much on the data gathering, but on the data usage side, and making bad uses of those data illegal and have teeth to them. And in many cases, they really do. I mean, most companies, I would say, live in fear of ever violating privacy on any of those data, because like your first offense can be a $5 million fine. And if you do it for a lot of people, it's a lot more than that. And so it's a definite worry. I think the prosecution aspect you bring up is also very important. I think it's probably it would be unlikely that any company that was involved with this kind of data wouldn't want to run away from that as hard as they possibly could. But I do think it's well worth thinking about lobbying efforts and ways to put as much protections in as possible.
So I am going to cut us off there. I am cognizant of the fact that we have a clock here and we're running out of time, and a good moderator always pays attention to time. I'm going to leave you with one thought at the end of this, and that is, in order to be able to responsibly use artificial intelligence, you have to use another AI, and that's actual intelligence. So thank you all for attending. We appreciate it.
Excellent. Thank you so much to all of our panelists for their insights into